Hello everyone, it's Dr. Locklear here, and today we are talking about the concept of perfusion. And our exemplar is 16M on page 1325 of your text, and we are actually talking about brain attack or stroke. This can also be called a CVA or a cerebrovascular accident. So we're going to be looking at the things that cause a stroke and how it affects the patient. A stroke is very debilitating. Patients who experience a stroke have an array of symptoms that can be from mild to moderate to severe, and depending on the severity of the side effects depends on how the patient's life is changed in regards to being able to communicate, take care of themselves, continue to work, a multitude of things. It is a disease that has severe side effects from it. Our learning outcomes are looking at the different types of stroke. We're going to look at 4 to 5 different types and what the cause is in each type. What is the patho? How does a stroke occur? What are some of the causes? What are the risk factors? Some are modifiable, some are not modifiable. The clinical manifestations. What do you see when someone has a stroke? What are some of the immediate symptoms? Because when you're having a stroke, there may be immediate symptoms. What are the diagnostic tests that we run? What are the CTs, MRIs? What are they looking for? What blood work? What type of therapy? These patients need very intense therapy in PT and OT and speech because their speech can be gravely affected. What type of care do we need for patients across the lifespan? Infants can suffer a stroke. Children can suffer a stroke as just like an adult, and the symptoms are very similar. So how do we meet the needs of a newborn infant that suffered a stroke from a mom that had eclampsia? And then, of course, how do we apply the nursing process? What do we see in our assessment? What do we assess? What do we observe in this patient? Which nursing diagnoses are the most pertinent, have the highest priority? These patients need to be kept safe. And then what are the nursing interventions? This is going to be a very detailed recording of this chapter, so just hang in there with me, okay? So our overview, a stroke, also known as a cerebrovascular accident or brain attack or a CVA, results from neurologic deficits from a sudden decrease in blood flow. So somewhere in the brain, the blood flow has been occluded from whatever reason, and we're going to talk about those. And once the blood supply is cut off, of course, the oxygen is cut off and the tissue and cells start to die, and therefore causing the attack. And when this decrease in blood flow occurs, you will see immediate symptoms. Strokes can be ischemic. So this occurs when the blood supply, so ischemia means oxygen. It occurs when the blood, well, it doesn't mean oxygen. It means death to the cell from lack of oxygen. That's what it means. It occurs when the blood supply to part of the brain is suddenly interrupted by a blood clot, an embolus, something going through that vessel that causes an occlusion, such as a stenosis or narrowing. It may be hemorrhagic. This occurs when a blood vessel breaks open and spills blood into the spaces surrounding it. The neurologic deficits caused by the ischemia and the necrosis of the brain cells, because when we don't have enough oxygen, the brain cells die. And it does vary according to the area of the brain, the size of the affected area, and the length of time, because we're going to see in a TIA, which is a transient ischemic attack, that occurs for a brief moment, just a short period of time, and then the vessel opens back up and the blood supply returns. So you may see mild symptoms, but not a true stroke. But recurrent TIAs are a sign of impending strokes, and we'll talk about that. A major loss of blood supply to the brain, for example, in a hemorrhagic stroke, causes severe disability or death. People can die from a stroke. It is an immediate situation, and it is an emergency. When the duration of decreased blood flow is short and the area in the brain is small, the involvement small, then the individual may not be aware that anything has happened. So again, you may just see minor side effects because maybe the occlusion was very short, or you may have severe damage to the vessel and the side effects are permanent. Once you have paralysis from a stroke, that cannot be repaired. You'll always be paralyzed. Strokes occur more frequently in men than women, although the risk of stroke is greater for women during pregnancy and for the first 6 weeks postpartum, and this is due to blood clots, and maybe this mom had high blood pressure and became experienced preeclampsia or eclampsia during the pregnancy. So what is our patho? So when the blood flow and oxygen to the neurons in the brain are decreased or interrupted, you're going to see changes at the cellular level take place immediately within 4 to 5 minutes. The cellular metabolism ceases as the glucose, and we do have to have glucose. Glucose gives our cells energy. Glycogen and the ATP are depleted, and then the sodium and potassium pump fails. So in other words, the cell is starving. It's not getting the energy it needs from the glucose. It's not getting those ions such as sodium and potassium that help it function properly. All this is cut off. The cerebral blood vessel wall starts to swell, and because there's a occlusion there and the blood supply is backing up, it can't get through. Think about plumbing. You got a clog, and we need some Drano in there to get it opened up. So you have this further occlusion, and so the vessel starts to swell, and it can rupture. Everything beyond the occlusion is cut off from the blood supply, and that's where you're going to see the evidence of the stroke. Cerebral blood vessels swell, further decreasing blood flow, so even the swelling causes a decrease in the blood flow as well. You'll see when circulation is restored that vasospasms and increased blood viscosity can continue to impede blood flow. Well, the blood can get thick from the clotting factors. And so even though it once opens up, you still may have some deficits there because it's thick now from the process. Severe or prolonged ischemia, and that's lack of oxygen, leads to cellular death. A central core of dead or dying cells is surrounded by a band of minimally perfused cells called the penumbra. These cells in the penumbra, they have impaired metabolic activity, so their cells not able to function appropriately, and metabolic, those glucose stores are being cut off. Their structural integrity is maintained. The survival of these cells depends on the timely return of adequate circulation, the volume of toxic products released by the adjacent dying cells, because when a cell dies, it does release toxins, and the degree of cerebral edema, so that's swelling in the brain, and alterations in local blood flow. So we have a lot of things going on here. Something caused an occlusion, and now the cells are dying, the vessels are swelling, and the swelling can continue even after the blood flow is returned. A stroke is characterized by gradual or rapid onset of neurological deficits, and this can be a compromise in the cerebral blood flow. The neurological deficits that occur are often identified at the area or the junction of the region in the brain where the occlusion occurs. Because the motor pathways cross at the junction of the medulla and the spinal cord. Strokes lead to loss or impairment of sensory motor functions on excuse me, on the side of the body opposite the side of the brain that is damaged. So if I have a stroke on the left side, my right side's going to be affected. If I have a stroke on the right side of my brain, then the left side of my body will be affected. So for example, if I have a right brain stroke, I may have symptoms on, you'll see symptoms on the left side, paralysis, those type of things. If I have it on the left side, I'll see symptoms on the right side of my body. This is known as contralateral deficit. A stroke in the right hemisphere of the brain is manifested by deficits in the left side of the body, and a stroke in the left hemisphere is manifested by deficits in the right side of the body. So contralateral deficit. So what are the different types of stroke? We have ischemic stroke, a TIA or a transient ischemic attack, thrombotic stroke, embolic stroke, and hemorrhagic stroke. And we're going to take a slide and look at each one of these. So ischemic stroke. This is a blockage or a stenosis, so a narrowing of the cerebral artery, and it can be caused from a blood clot. It can be caused from plaque buildup. It can be caused from a thrombi, which is something traveling through the vessel that will occlude it, or small vessel disease. So you may have vessels that are very narrow, and the blood flow is cut off because it's narrow through there. So in other words, ischemic, there's a blockage from some reason, a blood clot or whatever, and it cuts off the blood supply to that area, which decreases the oxygen, because we know the red blood cell and the hemoglobin in the red blood cell carries the oxygen. So if the blood supply is cut off, I am losing oxygen to those tissues, and ischemia we know is death to a tissue and it will die. So with your ischemic strokes, you see transient ischemia attack, which is a TIA, or often referred to as a mini stroke, and a lot of people will say that. Deficits last for less than 24 hours, so you may see symptoms, but they do start to resolve or go away. They may be present for a few minutes or just a few hours. A stroke is usually determined by how the symptoms progress. If the symptoms continue to progress, then they will identify it as a true stroke. Again, less than 24 hours, it's probably a TIA. So some of the causes of a TIA, and there's many things listed here in your chapter as well, on page 1326. But inflammatory artery disease, sickle cell, atherosclerotic changes, so those hardening of the vessels, thrombosis, your clots, and emboli, and clots again. Neurologic manifestations depend on the location, the size of the cerebral vessel. And look on page 1326, it gives you some manifestations, have sudden onset and often disappear within within a few minutes. Commonly occurring deficits are contralateral numbness or weakness of the hand, leg, forearm, and a corner of the mouth. And so you may see a patient look funny, and they may just have this look on their face. Their corner of their mouth may be drawing. They may complain of numbness. They may have some slurred speech. They may be, they just don't look right. Their level of consciousness has changed. So when you see sudden changes in someone, or maybe that morning they got up and it just didn't look right, and within a couple of hours their level of consciousness had changed. You see a little drawing of their face, or they say, oh, my arm feels numb. Again, it can occur over a few hours. So the next one with ischemic strokes is the thrombotic stroke. This is occlusion of the large cerebral vessels caused by a thrombus, so some type of blood clot. It's most common in resting or sleeping adults. What you'll see, lower blood pressure in the sleep, less pressure to push the blood clot through. If I have high blood pressure, then it puts too much pressure on the vessel and it may rupture, which that's a hemorrhagic stroke. Some of the common locations are the internal carotid artery, vertebral arteries, junction of vertebral and basilar arteries, and your lacunar strokes, and these are your smaller vessels in your brain. It usually affects only one region of the brain, and it's rapid but progressively slowly occurs over 1 to 3 days. So with your embolic stroke, and all of these are on page 1326 and 1327. So if you read through those, the information is very self-explanatory. So the embolic stroke is a blood clot or clump of matter traveling through cerebral vessels, and it becomes lodged. And so once it becomes lodged, it occludes the vessel. And so it may be lodged in a vessel that's too narrow. We all have blood clots. All of us have blood clots traveling through our circulatory system all the time. But our vessels are, big enough to let it go on through. The pressure is strong enough to push it through. So don't think you just suddenly have a blood clot. Most people have these, and it's when they can't get through or they're too big and they occlude, that's when you have problems. Sometimes when you may feel a little lightheaded, who knows? It might be just a little blood clot trying to pass through. So the area of the brain supplied by the blocked vessel becomes ischemic. The oxygen, the blood's cut off, so it's dying. And it can be very painful. Some people say, I have a sharp pain in my head. And it's painful when the tissue is dying. The most frequent site is that bifurcation. So that's where the vessels come together, and it's like two roads where the two roads meet, and then they make one road. So that little point, that little V where the two roads come together, that's the bifurcation of the vessels. Seen in patients younger than those with thrombotic strokes, occur when the patient is awake and active, because we know the more active we are, the more pressure it puts on our vessels. The origins are the thrombosis in the left chamber of the heart during atrial fibrillation. So patients who have atrial fib are at high risk for stroke because their mitral valves can't, the clots get hung up in those and it can't push them through. So that's why they have to be on medication to keep these mitral valves working, to keep the blood flowing through properly. Carotid artery, atherosclerotic plaque. So in other words, I got a cholesterol plaque build up in my vessels. Bacterial endocarditis, a recent MI, because we know there's damage to the heart muscle with an MI. Along with endocarditis, that's infection. It affects the pumping action of the heart. Same thing with rheumatic heart disease and ventricular aneurysms. All these affect the pumping action of the heart, which affects the ability of the heart to pump the blood through and keep these blood clots going through. Sudden onset, immediate deficit. So, when the occlusion occurs, it's immediate. You immediately, when that blood supply is cut off, with an embolic stroke, you will see deficits immediately. A hemorrhagic stroke, or also called a intracranial hemorrhage. It can also be called a cerebral hemorrhage or subdural. Look on page 1327. Two types of hemorrhagic strokes: intracerebral hemorrhage and subarachnoid hemorrhage. And so I actually saw a patient one time die with a cerebral hemorrhage, and the blood came out of his eyes, his ears, his nose, his mouth. It was a very traumatic experience, and within just 2 minutes he was dead. I will never forget the look on his face. It was very tragic for him, and there wasn't anything we could do. When it happens quickly. Most of these people do not survive hemorrhagic strokes. So what happens? You have a ruptured blood vessel in your brain. So in other words, you got a blowout in your tire, a hole. There's a hole there. It occurs suddenly, often when the person is active. They have bleeding in the brain. There's bleeding into the spaces around the brain, which is subarachnoid. Bleeding in the brain is intracerebral. And the patient these are some of the patients that will say, oh, I have a sharp pain in my head. And then all of a sudden, when they say that, they pass out. Hypertension is the most common, putting pressure on those vessel walls to the point that you have bulges and these bulges rupture. Again, the wall is ruptured and there's trauma, erosion of the blood vessels by tumors, arteriovenous malformations. There may be a malformation of the vessel. Anticoagulant therapy, it can thin the blood too much and you can bleed out through the vessel. The outcomes are very poor. The onset of the manifestations are rapid. Again, this is a medical emergency. Most of these people do not survive. They have pressure on the brain because the body's still circulating and the blood's building up in the brain. So now I've got blood in these spaces that shouldn't be. I'm losing blood to the vessels beyond it. So I'm losing oxygen. My brain is dying. It says the onset manifestations from a hemorrhagic stroke are rapid, and it depends on the location of the hemorrhage, but you will see vomiting, headache, and again, it's like, oh, my head's hurting, it's sharp pain, seizures, hemiplegia, so some paralysis, and loss of consciousness. Pressure on the brain tissue from increased intracranial pressure causes coma and death. And again, the survival rate from hemorrhagic strokes is small, very small. I have a gentleman in my church that had a hemorrhagic stroke and he survived. It was unbelievable. He survived. He is definitely a living medical miracle. Yeah. Some of the risk factors: hypertension because of the pressure on the vessels, heart disease, atrial fibrillation because the chambers again don't beat effectively, the blood pools, and these clots are in the heart, and it can't get them out. And if a clot dislodges, because these clots are in there, they can't get through the valves. It can get through at some point and maybe lodge in a vessel. So as the heart's pumping the blood through, that pumping action helps try to reduce some of these clots too. That's why people with atrial fibrillation, we need to make sure that that blood is going through those heart chambers as normal as possible and quickly. When it backs up because the mitral valves don't work, it'll clot. Okay, and I hope that makes sense. Diabetes, because we know diabetes causes changes to the vessels and it can make them very hard and narrow, and it can be affected by high blood pressure and blood cholesterol and being overweight as well. Sleep apnea, because sleep apnea, you don't have enough oxygen. Cholesterol levels, smoking, because we know that it narrows the vessels. Sickle cell, because the changes in the size and the shape of the RBC, and they clump together and form clots. Very susceptible to a stroke because of the clots. Substance abuse. We know that certain drugs can decrease cerebral blood flow. Marijuana, anabolic steroids, heroin, amphetamines, and cocaine. Some of those are the main ones. Living in the stroke belt. If you are from the South, you are considered living in the stroke belt because of the diet here. It's very high in fat and sugars, which makes us more prone to being overweight and to having high cholesterol. When these plaques break off, they can either cause a heart attack or a stroke. Ethnicity, some African Americans have almost twice the number of first ever strokes compared to other ethnic groups. You will see an increased incidence of intracerebral hemorrhage, subarachnoid hemorrhage, ischemic stroke, TIA, and TIA at a younger age in the African American population. Other risk factors for stroke include obesity, sedentary lifestyle, just laying around, not getting your circulation up, recent viral and bacterial infections, previous TIA, and again, remember, TIAs or mini strokes are warning signs that a bigger stroke may be coming. Needs to be treated immediately. Other risk factors for women: hormonal contraceptives, because they do have a tendency to cause blood clots. The contraceptives do. Some of the other things: pregnancy, childbirth, menopause, and migraines with an aura, and autoimmune disease like diabetes and lupus, and clotting disorders. Risk is highest immediately after a previous stroke. So if you've already had a stroke, which means there's issues there that caused a stroke, you're susceptible for having a stroke again. Just because you have one stroke don't mean you won't have another one. So how do we prevent? The National Stroke Association has a 3-step guide, and this is on page 1328. And some other things before we get to the guide. You want to control your blood pressure, lower your dietary intake of cholesterol and saturated fats, quit smoking, control your diabetes, exercise, get the weight off, go to a support group for stroke prevention, high fruit and vegetable rich diet because they don't have fat in it, so low fat diet. Antiplatelet drugs, and we're going to talk about some of the drugs as we go through. And you need to take the medication, as I've said before in class. When you're on medications, you have to keep taking them even when you feel better so they stay therapeutic in your system. So for the 3-step guide for preventing a stroke, you need to look at these 3 things. Review the risk factors to help identify personal risk for stroke. So what are your risk factors? Reduce the risk factors through lifestyle changes. So these are modifiable. We can make changes. We are in control of our health. And recognize the signs and symptoms of stroke by the FAST, F-A-S-T. Is there facial drooping? Is there arm weakness? Is speech slurred? Then this is time to call 911 if these symptoms are present. So call 911 if you have sudden weakness, numbness in the face, arm or leg, confusion, difficulty speaking or understanding speech, difficulty with vision, blurred vision, blindness, you just can't see, and then severe headache. And this is like a headache, like I said. Oh, my head hurts. It's so sharp. The pain is so sharp. Look on page 1328 and 1329. You have box 16-24 and 16-25. Manifestations of stroke by the involved cerebral vessel. So according to which vessel it is, you will have specific symptoms. The bottom one, vertebral artery, pain in the face, nose, or eye. That one just really caught my eye. I've never really heard of that one before with pain in the nose or the eye. So somebody that has like severe allergies or sinus problems, they have pressure in their nose and eyes and face all the time. So you have to make sure that you're looking for some other symptoms as well, like problems with gait and dysphagia, which is difficulty swallowing. Box 1625 is complications of stroke throughout the different systems. Make sure you read through this because it gives you detailed list of what you'll see in each system of the body. Of course, neurological going to be the biggest one. Changes in level of consciousness, communication, visual, behavior changes. People that have a stroke do have behavioral changes, and they may become very aggressive and violent and verbal, and they may say stuff that you would have never thought this person would have said. I've heard family members many times say, my mother never taught that way, but it does change their personality. And so they have loss of sensation to touch, pain, heat, cold, and pressure, hyperthermia, neglect syndrome. Often the side that is affected is neglected, or they may neglect the other side, and we're going to talk about that. It's on page 1329, because they just cognitively are not aware of that side. So make sure you review these boxes here, okay? Clinical manifestations, again, vary according to the artery involved or the area of the brain affected. Women more likely to report non-traditional symptoms. I'm disoriented, I'm confused, you can tell somebody's changing mental status. Sudden focal, usually on one side. So again, If it's the right side, you'll see left side symptoms. If it's the left side of the brain, you'll see right side symptoms. Most common are weakness of the face and arms and sometimes leg, numbness on one side, loss of vision, speech, and it's usually slurred, and sudden severe headache, and difficulties with balance, and then your stroke syndromes, and that's in box 1624, as I've already gone over. Okay. So, some other things that you may see, and this is also in box 1625, hemianopia, agnosia, apraxia, neglect syndrome. What are these? So, hemianopia, I'm sorry, it's nopia. It's the loss of half of the visual field of one or both eyes. When the same half is missing in each eye, the condition is called homogeneous hemianopia. Opia is opia. Agnosia is the inability to recognize one or more subjects that were previously familiar. Agnosia may be visual, tactile, or auditory. So, I don't know, you may look at a picture of a family member and not know who it is. Apraxia is the inability to carry out some motor pattern like drawing, writing, getting dressed, coordination issues. You're not able to address yourself. And then again, neglect syndrome or unilateral neglect. This is the patient has a disorder of attention. The patient cannot integrate and use perceptions from the affected side of the body or from the environment on the affected side and therefore ignores that part of the body. They may even deny paralysis. So what's that mean? I have a patient that's paralyzed on the left side and they're sitting up in a wheelchair and their left arm is paralyzed. They can't move it. It's hanging over the side of the chair. They're leaning to the side and their arm is turned blue because it's just so dependent, and they're slumped over to the left side and they don't realize that their arm is hanging, and they don't take their good arm and move it and pull it back over or sit themselves straight up. You will see this a lot in patients with stroke. You will often have to help reposition them a lot. In severe cases, the patient may even deny the paralysis. The deficit's more common following a stroke on the right side, where damage to the parietal lobe results in perceptual deficits or issues with the eye. And then pain and discomfort. You may see this with a stroke. You may have acute pain, numbness, or strange sensations, tingling, burning, stabbing pain, and you'll see this in the extremities. It's not uncommon, but damage to the thalamus may cause central stroke pain or central pain syndrome. And this is where you have hot and cold feelings, burning, tingling, sharp, stabbing pain, most often in the extremities. It worsens with movement and temperature changes. The painful sensations are not relieved by pain medications, nor are there any specific treatments. So in other words, it's neurological damage and it can't be fixed, and they may have to deal with that. And then in your cognitive changes, you see changes in level of consciousness. You see emotional lability. Well, what is that? Labile emotion. You may not respond to anything emotional. You may just be labile, and what that means is really no response. I may tell you something that I know may upset you, and you just look at me with no understanding of it. Your emotions just labile. You just don't understand what I'm saying. Or you may cry when you're trying to laugh, or you may laugh when you're trying to cry. So the emotion may be opposite. You may have a loss of self-control, decreased tolerance for stress. Again, these patients get irritated very quickly. Some of them do, not all of them. You may have memory loss, decreased attention span, poor judgment, and inability to think abstractly. You do have a change in your mental status. Your brain is affected. You've got deaf to tissues there. You can't think like you used to think. Some people are able to even talk after having a stroke. Look on page 1330. You have some terms here. You do need to know these terms. Aphasia is the inability to use or understand language. Inability to use it or understand it. So you can't say it or you can't process it. Expressive aphasia, this is where you have a motor speech problem in which the individual can understand what is being said, but they can't express back to you. They can't talk to you. This is also called Broca aphasia. Receptive aphasia is where the individual cannot understand the spoken, often written words. Speech may be fluent, but it's inappropriate. This is called Wernicke aphasia, and you see this with alcoholics or Wernicke. Okay, Wernicke or Wernicke. And then you may have both. You may have mixed. And then you may have dysarthria, and this is any disturbance in muscular control of speech. So your speech can be highly affected with a stroke because you got dead tissues and vessels and cells in your brain that don't work anymore. It killed that area, okay? So now you may see some motor deficits. So you may have mild weakness to severe. You may have paralysis in your fingers and hand and not your arm, but you may have paralysis to your arm and not your leg. You may have paralysis to your arm and your leg. And so this is what we call hemiplegia when it's one side of the body. So hemiplegia, this is paralysis of the left or right half of the body. Hemiparesis is weakness of the left or right half of the body. Flaccidity is the absence of muscle tone or hypertonia, and spasticity, I'm so sorry, these words are hard to say, but I do know what they mean. Spastic, okay? It's increased muscle tone, hypertonia, so you may see some flapping and moving and jerking of that body part. And then you may have issues with the affected arm and leg are always initially flaccid and then become spastic within 6 to 8 weeks. The spastic symptoms often cause characteristic body positionings, so adduction of the shoulder, pronation of the forearm, flexion of the finger. So in other words, it may be in a position that it shouldn't be in at all times. Foot drop. They can't move their foot up when they're under the covers. That's why you don't pull the covers tight over their feet, because it'll pull their feet down and they can't move their foot to get it back in place like we normally can when we're under covers, okay? Motor deficits resulting from stroke may result in altered mobility. So you may see multiple body systems and include orthostatic hypotension, increased thrombus formation, decreased cardiac output, impaired respiratory function, osteoporosis, and so forth. Because we have these issues with immobility that affects these particular body parts, okay? So when I have paralysis and I'm not able to get up and walk and move around, you know, I'm going to see other changes affected as well. Then elimination. Because of the neurological damage, it may affect our ability to control our bowel and bladder. So we may go from being continent to incontinent. And so you may have partial loss of the sensations that trigger bladder elimination, resulting in urinary frequency, urgency, or incontinence, and the same thing with your bowel habits as well. So what are the treatments? The treatment is 3 stages: stroke prevention, acute care immediately after stroke, and rehab. So what we want to do is treatment during the acute phase focuses on diagnosing the type and cause of the stroke, supporting cerebral circulation, getting that circulation, keep it going. So what are we going to do to do that? And controlling or preventing further deficits by preventing another stroke. The overall goals of stroke defined by the AHA, this is the American Heart Association, are to minimize brain injury and maximize patient recovery with these four things: rapid recognition and reaction to stroke warning signs, rapid emergency medical services, call them immediately. Do not wait. Don't wait. Even if the person says no, no, you call for them anyway. Rapid EMS system transport to the hospital, and rapid diagnosis and treatment in the hospital. There are time frames on some of the medicines we're going to look at. Look on page 1331, and you have etiology, clinical manifestations, and clinical therapies. And please read over this. This is in your reading. They just take it and put it in a nice chart for you. And so go back over this as a quick guide as well, but I've already covered most of that. So for diagnostic tests, this begins with a complete history and careful physical exam, including a thorough neurological exam, neurochecks. And after a stroke, the patient may need to be on neurochecks every hour to make sure that they're not having another stroke or the symptoms aren't getting worse. The time of onset of stroke manifestations is critical. The National Health Institutes or the National Institutes of Health Stroke Scale is a clinical evaluation tool that they use to determine the neurological degree of the damage. And this is table 16.31, and you will see that on page 1332. Level of consciousness questions, and level of consciousness commands, and then you have a scoring there. And we know when we do neuro assessments in the hospital, we use the Glasgow Coma Scale as well. Imagery studies, these are used to identify an increased risk for stroke or to identify the pathophysiological changes. So CTs, MRIs, the Dopplers, the PET scans, and they're looking to see where the vessel was affected in the brain. Where is the stroke at? And then you have the plaque test, and this scans the blood for high levels of lipoprotein associated phospholipase A2, which is more common in individuals who have had strokes. For some patients, a lumbar puncture may be performed to look at the cerebrospinal fluid as well. A thrombotic stroke may elevate the CSF pressure. After a hemorrhagic stroke, frank blood may be seen in the CFS as well. Removal of CSF when intracranial pressure is increased can result in herniation of the brainstem. Therefore, this is a safety alert on page 1332, lumbar puncture should not be performed in patients with increased intracranial pressure. Please note that, and not just for testing purposes, okay? You need to know that, all right? Pharmacological therapies. We have antiplatelets to keep the platelets from clotting, antihypertensive drugs to keep the blood pressure low, of course, cholesterol drugs to keep the cholesterol down, your statin drugs, and I know you guys are learning all about these types of drugs in pharmacology as well. Your antiplatelets, and there's a whole list for you here on page 1332 in the reading. You have aspirin, Plavix, Persantine, Ticlid. All these are good for patients that are at risk for TIAs. Often with Ticlid, you have to put the patient on an EKG, do an EKG, and look at their QRS complex and make sure it's not too wide. Ticlid is a platelet aggregation inhibitor that reduces thrombotic stroke. In patients with atrial fib, you will see anticoagulants like Coumadin or warfarin, Xarelto, Eliquis, Pradaxa, Savacea. These help by preventing clots. But all of these, you have to look at the labs on these, the PT and the INR, because these Coumadin's a blood thinner, and so we need to make sure that the blood is not too thin. If it's a high blood pressure problem, then of course certain antihypertensive medications such as your thiazide diuretics, your CCBs, your ACE inhibitors, your beta blockers, all of these, because we need to keep that blood pressure down. Okay, and then of course your statins, Lipitor, Zocor, Mevacor, Tricor, Fibrocor, anything that's got core on it or statin on the end of it, you should know that's a statin drug. Corticosteroids to help relieve the inflammation and the swelling of the brain. You've got a note here. It says management of hypertension during is controversial. With the blood pressure medicines, it's antihypertensive therapy is another common preventive measure, and it lists these for you. Even though beta blockers are useful in lowering blood pressure, they are of only limited effectiveness in prevention of stroke. Like high blood pressure, cholesterol levels also increase it as well. So management of hypertension, you have to be careful to make sure we're not dropping the blood pressure too low, because some patients, as you've already seen in clinical, are on 2 or 3 or 4 different blood pressure medicines, and so the blood pressure has to be monitored very carefully when you're doing blood pressure management for at any time, not just for strokes. Okay, surgery. Well, before I go to surgery, go back to page 1333. I want to talk about the TPA, and this is so important. So if you're having an acute stroke, you want to know and anticipate that the physician may order fibrinolytic therapy using the recombinant tissue plasminogen activator altipase, or RTPA or TPA. This is the gold standard for the treatment of acute ischemic stroke. This drug converts plasminogen to plasmin, which results in fibrinolysis of the clot. So what does that mean, Dr. Locklear? It breaks up the clot. So according to the Stroke Association, TPA, this is so important, is most effective when given IV within 3 hours after the onset of manifestations. That's why it is so important to act fast, get them to a healthcare facility so they can administer TPA in a timely manner, and because once that time frame passes, it's too late. It says in patients age 80 and under without a history of diabetes and stroke, prior to TPA can be administered up to 4.5 hours after the onset. To prevent stroke reoccurrence, patients who receive TPA typically begin anticoagulant or antiplatelet therapy no sooner than 24 hours after it's been given. Now listen to this, this is important. In patients for whom TPA is contraindicated, if you're over 80 years old, you have a history of diabetes and stroke, pharmacologic treatment of acute ischemic stroke is usually limited to administration of aspirin. Aspirin is a potent little drug, and before you give aspirin, and I know I'm speaking to both sections because you all will be listening to and I don't have section 1 in my clinical. Please look at your platelet levels before you give aspirin. I'll give you an example. We had a patient in the hospital the other day. Their platelet level was 128. It had dropped 50 points from the day before within 24 hours, and the patient had aspirin ordered. It was held, and the doctor was notified, and the doctor held it and did some more blood work. Please, please check. Don't look at aspirin and say, oh, it's just the aspirin. Aspirin is very potent drug. So please look at those platelet levels. Antiplatelet and anticoagulant drug therapy is not routinely recommended, although there are a few specific clinical situations in which it may be useful in patients with atrial fib who are experiencing stroke caused by embolism that originated in the heart. In these cases, the most commonly used medications are heparin, and if you're getting heparin, then you're going to have a PTT and a APTT. with heparin if it's IV. Warfarin and Lovenox, and you all probably have given Lovenox. These medications do not dissolve a clot, they prevent further extension of the clot and formation of new clots. Sodium heparin may be given sub-Q or by IV, while warfarin sodium is being given orally. But remember, these are potent medications, so when you're on these medicines, you need to monitor for bleeding. If the patient has bleeding from the gums, their nose, bruises, if they have a Foley catheter and the urine in the Foley bag is red or pink tinge, you need to don't give them call the doctor because they're bleeding from somewhere. Anticoagulant and antiplatelet medications are never administered to a patient with a hemorrhagic stroke. This is your safety alert. Hemorrhagic stroke involves bleeding in the brain, so administering these drugs would perpetuate the bleeding and worsen. Of course it would, because they are blood thinners. They're going to make the blood flow faster, and if I have a hemorrhagic stroke, I don't need to do that. Okay, so surgery. Please make sure you read that section very carefully on TPA. Surgery, carotid endarterectomy. So they're going to go in. There's a picture of one on page 1334. They're going to go in and clean out the artery, or an artery bypass, or a stent with angioplasty. And so with these, you want to monitor, for this is a surgical procedure, so monitor your patient after they come back from surgery. Rehab, physical therapy to help prevent contractures and improve muscle tone and help the patient with exercise, hopefully can walk again or learn how to walk with a cane, walker, some type of prosthesis. Occupational therapy helps with devices, like to help feed themselves, put their clothes on, their shoes on, so you may have to use certain devices. And then, of course, speech therapy for those patients who have suffered aphasia. Stroke in neonates, it's the greatest risk immediately before birth to 30 days after birth. Labor and delivery can increase the stress on the arteries, especially in the head, because you're pushing that head through such a small space, a lot of pressure there. Warning signs. This is important because we often miss these. They can be vague and diagnoses very uncommon. So with infants, seizures, and they're sleeping a lot. They sleep all the time. They only maybe wake up to feed and they go right back to sleep. Favoring the use of one side of the body. Repetitive facial movements, staring, apnea, jerking of the muscles of the face, arm, and legs. And then they list the two most common types for you, sinovenous and arterial ischemic stroke. Damage can be minimized because healthy areas of the brain compensate because, this is a neonate, their brain is still growing and changing. Permanent deficiencies may occur just like with the adult. And as you read on page 1335, with stroke in children and adolescents, the symptoms are pretty much the same as they are in an adult. So children and adolescents, more common in children under age 2, more common among the African American male population. Common causes of adult strokes are rare in children. It's some of the same reasons. A newborn's not going to have elevated cholesterol, okay? That's what it's talking about there. Symptoms, severe headaches, vomiting, sleeplessness, dizziness, seizures, language, and loss of balance or coordination. So you may see developmental delays, especially in a child under a year old. Children and adolescents, the most common types are arterial and sinovenous, generally more resilient than adults in recovering because they're young, and we know young people can bounce back a little better than us old folks. High risk for recurrent stroke because, some children are very active, athletes that play a lot of sports, get head injuries, those type of things. And then here's your treatments, controlling the high blood pressure. Yes, children can have high blood pressure. It's not that common, but it does happen. And then your thrombolytic therapy, surgery to relieve the intracranial pressure, and use of TPA is controversial in children. It's more for the adult. Your pregnant patient, of course, pregnancy increases a stroke because we have more volume, we have more fluid volume, and there's more pressure on the vessels. Preeclampsia, elevated blood pressure, increased risk in the third trimester because the fluid volume's getting larger, the baby's getting bigger, okay, and use of TPA is limited for the pregnant patient. Nursing process is very complex and multidimensional. Continuity of care is vital. Starting care immediately is vital. Knowledge and skill to meet the patient's needs. So we need to know how to treat somebody with a stroke. How do I give them their medicines if they're having swallowing problems? Maybe I need to call the physician and say, can we change this medicine to liquid? Do they need a feeding tube so they can eat and get their medicines? Many things. Do they need a modified barium swallow because they're having dysphagia, difficulty swallowing? Do they need a diet pureed with thick liquids? Do they need to be fed sitting upright with their chin tucked down, and you give them a spoonful and tell them to swallow? You have to give them cues when you're feeding them, okay? The assessment, observation and physical assessment, visible signs, paralysis on one side, facial drooping, difficulty speaking and understanding speech. What are their risk factors? Have they had a previous stroke? Do they use drugs? Yes, we have to ask that, and that is on the admission packet. Do you take illicit drugs? Do you drink alcohol? How often? When did these symptoms begin? How severe was it? Any incontinence, change in mental status? Who's your support? Because these people are going to probably go to rehab. Physical assessment, again, change in mental status, level of consciousness, weakness, motor strength or lack of, balance and coordination issues, difficulty speaking, cranial nerve function, the side of their face feels numb, or their mouth is drawn, or their blurred vision in one eye. What are their score on the stroke scale? What did the Glasgow scale get? Vital signs, is their blood pressure still up? Is their blood pressure too low because we're treating them with 4 blood pressure pills? Skin integrity, are they starting to have breakdown because they have that unilateral neglect syndrome, and they don't know that their arm's pressing up against their wheelchair and they can't tell anybody because they can't feel it. Now you got a skin breakdown on your elbow. And of course your mobility status, can they walk, can they not walk? Your nursing diagnoses, risk for ineffective cerebral tissue perfusion. While you're having the stroke, it's not going to be risk 4, but it is going to be ineffective cerebral tissue perfusion during the stroke. And then there's a multitude listed there for you, and of course this is not all inclusive. So what are our goals in planning? Get that blood pressure down, understand the importance of cardiac rehab, ambulation, activities, PT, OT, and speech. Participate in these therapies. Keep them from aspirating when they have swallowing problems, because we know aspiration leads to pneumonia. So maintain cerebral perfusion. Assess their airway. Is it patent? Did they get choked while eating? Are they having respiratory issues because of the neurological damage? Their part of the brain is affected that tells them to breathe. Some of these people end up on a ventilator and they never come off of it. Avoid prolonged suctioning. It can increase intracranial pressure. Follow your guidelines if they need to be suctioned. All of your interventions are on page 1336, 1337, and 1338. And you have maintained cerebral perfusion, physical mobility, urinary and bowel elimination, and maintaining safety. And I'm not going to, the PowerPoint's about an hour long now, so I'm going to try to cut it off very shortly, okay? Again, cerebral perfusion, all these are listed for you. Please make sure that you read through this. It talks about reflexes and strength and gag reflexes and swallowing problems, monitoring the blood pressure, monitoring the heart rate, monitoring for what's called hyperthermia. So you need to monitor their body temperature, monitor their urinary output, Monitor for swelling, monitor for seizures. What do we do for seizures? Pad the side rails, administer the anticonvulsant medications. Make sure we're turning and repositioning every 2 hours. Make sure you read through these, okay? Again, physical mobility, active range of motion to the unaffected side. The affected side will be passive range of motion. Turn and reposition. Look at their skin. They're very susceptible to skin breakdown on their hands, feet, bottom. They're susceptible to blood clots. Do they need SCDs? This range of motion is going to help. They need physical therapy. They need to be up. Even if they're totally debilitated from the stroke, we still don't lay them in the bed, get them up in a chair. Promote self-care. Try to maintain their independence as much as possible. It takes time to work with these patients. Let them do as much as they can. Teach the patient to dress the affected extremity first. Okay, so encourage use of the unaffected limb for self-care. So you want to teach the patient to put on clothing by first dressing the, listen to this now, okay? And I said that wrong. I'm going to go back and re-say this. Teach the patient to dress the affected extremity first, the weak side first, because I can take the good side and help put on my weak side, and then I can move the good side and get it on. So on page 1337, because I don't want to say it wrong, and I think I said it backwards on my first sentence. Teach the patient to put on clothing by first dressing the affected or paralyzed side, and then dress the side that's unaffected, that's not paralyzed. I hope that I said that I've got it correct, okay? So you put on the weak side first, then the good side, okay? And then when you undress, you do it backwards. You take off the good side first, and then you take the good hand, and you can help pull it off on the affected side, okay? I hope that makes sense. Just read that section, it does, but I hope I corrected myself. Communication, don't rush them. Give them time. You may have to use written instructions. You may have to use sign language, a communication board, flashcards, writing tablets. It can be very difficult to communicate with these folks, and they may need speech therapy. Bowel and bladder training. And I don't know if you guys know about bowel and bladder training, but what you do is you take the patient to the bathroom every 2 hours while awake and right after, within 30 minutes after they eat. They may use the bathroom, they may not, but at least you're getting their body used to a routine. That's called bowel and bladder, it's called restorative bowel and bladder training. You want to teach Kegel exercises, and this is where the patient tightens the muscles as though stopping urination and then releasing it. And you want to hold it for 5 seconds. That helps keep that bladder tone as intact as possible, okay? Even though if they're incontinent, you still get them up and take them to the bathroom every 2 hours. They may be on stool softeners. Give them to them. Monitor their bowel movements. Monitor their bowel sounds. Make sure they're able to swallow without difficulty, and we want to encourage up to 2,000 milliliters a day and a high fiber diet. And some of these patients are on fluid restriction and sodium intake restriction. They may be on a low sodium diet. Well, most of them are. Make sure that you are following your fluid restrictions, okay? And then safety, dysphagia, difficulty swallowing, and it gives you very detailed instructions on page 1338. Sit them upright, do the chin tuck, put the food in, one little spoonful at a time, and encourage them to swallow. You may have to tell them, swallow, swallow. Right there, what it says, give step-by-step instructions. And then our expected outcomes. The patient will participate in therapies, communicate effectively. Significant other, we have to include the family and train the family on how to help these patients. And again, a lot of the stroke patients go to rehabilitation after the stroke to help with getting back to as normal as possible. I know this is long. It's about 1 hour and 4 minutes, so you may need to listen to it in increments of 20 to 30 minutes at a time. Thank you and have a great day.